3, 2, 1. Please start, sir.
Good evening, friends. Welcome to the 33rd edition of the PG Track program being run by the Cardiological Society of India Delhi branch. Today, we are into the 33rd edition of this PG Track program. It's been a great and a fantastic journey. I've got numerous mails by many of you who have asked and specially demanded for the statistical primer for the medical professionals. Reason because statistics is one of the things that we often not focus in our clinical studies. We think that we don't need it probably, we don't know it properly, or probably it will need more time and consume more of our time. And second thing is that this is one of the things which is now being commonly asked both in theory as well as in the practical exams. So it becomes all the more pertinent for us to know and have a very clear knowledge of the statistical primer for the cardiologists, for the physicians, and for everybody. So today I have a great privilege of having Dr. Anil Saxena, great electrophysiologist and also great teacher. And along with me on this journey, I have the privilege of having Professor Sumod Kurian, Professor of Cardiology from GE Pant Hospital. I have Dr. Satyaveer Yadav, who is Assistant Professor of Cardiology from All India Institute of Medical Sciences. So I requested Dr. Sumod to please introduce Dr. Saxena, and then we can go along with the session. Let me tell you, if you have any questions, clarifications, please put them down into the chat box. We'll be able to take these questions. In case you join late, you miss out this session, don't worry. This will be available on our YouTube channel. And this is part one of the statistical primer. Part two will be same time next week. So over to you, Dr. Sumod, please.
Once again, a very warm welcome to the PG Track program. As we all know, statistics, as Mohit told, is could be a very difficult subject. But as we all practice evidence-based medicine, one need to be very familiar as to how to interpret data. More than that, how to determine sample size, what is confidence interval, number needed to treat. All these things are very commonly asked questions in the Viva. So to teach us, we have Professor Dr. Anil Saxena, Director of Cardiac Electrophysiology from Fortis Escorts, New Delhi, here to explain to us the basics of statistics. We welcome sir to come and teach us, teach us statistics, sir. Please.
Thank you. Thanks a lot, Mr. Chairman. And it's indeed a pleasure to be here today in this program. I've heard a lot about this program, and it's really an honor for me to be part of this program. And I must thank Dr. Mohit Gupta and rest of the organizers for having me here. And as pointed out by Dr. Mohit, statistics is something which we have all feared all our career. And the main reason is that we do not know when to stop, because it is very important that we must look at statistics as something that is not our discipline, but at the same time, we are supposed to be familiar and literate about it. Just like when you use a computer or you use a car, you should know what are the different buttons, what are their functions, and when to press which button. If you know that much, you can drive a car perfectly, or you can use a computer perfectly to your advantage. But if you get into how does every button work and what is the mechanics behind it, what is the electronics behind it, then you will get so confused that you start backing off. And that is something that happens with the electrophysiology, with the statistics as well, that we must use it to our advantage as a science, as some technology, as a soft technology, and leave the rest to the statisticians, the calculation part. We must know when to use what statistics and how to use it and how to interpret it, because there are several reasons why we must be familiar or literate with the statistics. One is, of course, as pointed out by Mr. Chairman, that you have to pass your exam. All the fellows have to pass their exam, and sometimes questions may be asked both in theory as well as you may be asked about some particular trial, and they may ask about some statistical function. So we must be aware of that. Second is that you may be planning some studies. So to plan any studies, you must know the trial methodologies and how the statistics works. And thirdly, to read medical literature, because there's so much literature being published. And as most editors agree that 80% of the published research papers have some or the other defect, which is very, very gross. And we must be aware of all these issues before we interpret any trial or any finding and make decisions, any informed decisions based on that trial. So what is statistics? Statistics is basically, it is arrangement of an analysis of data in certain manner to derive meaningful information from that data. The data is generated when we gather data from the patients or the study groups in the form of value of variables. And these variables could be anything. I'll discuss about what are the different variables that we study. And then the data is organized and processed to answer a pertinent clinical question. So all studies begin with a clinical question as to what we want to see. And then we decide the trial methodology according to the clinical question. And then we perform or select and perform the statistical calculations. And all that depends on the data type and the research question. So in the two talks that I will be giving this week and next week, in the first today's session, I will discuss uh, what are the different type of data variables, what are measures of central tendency. Central tendency is when we look at a data, we want to know what exactly is the central tendency or the mean value. So there are three measures of mean, median, and mode. You must be aware of it. And then there are certain measures of dispersion. We want to see how much variation a particular set of data has. That is called measures of dispersion. Then I'll talk about what is the concept of confidence intervals, what are relative risk, odds ratio, and hazard ratio. Now, these three things are very commonly, we keep reading them in all the research papers. And many of us are confused about what exactly is the difference between relative risk, odds ratio, and hazard ratio. And then I will talk about the randomization and hypothesis testing, which is one of my favorite topics, which basically means how do we test a particular hypothesis and derive a p-value, and how to interpret that p-value. What does the p-value mean? Because you keep using this p-value less than 0.05. What exactly does it mean, and how should we interpret in our mind as to what is p-value? And the next week we will discuss how to compare the two groups, like we do t-test and we do the chi-square test. When are they used? Are there some other tests also which can be used in place of these tests? We will talk about the survival analysis, which is you must have heard about Kaplan-Meier curves, which are being discussed all the time, and all the trials have this Kaplan-Meier curve, which basically indicates survival free of some particular outcome. It could be mortality, it could be MI, it could be stroke, it could be anything. So survival analysis is a very important part. It comes as a short note. And then I'll talk about the ROC curves. It's spelled wrongly. So ROC curves, C index, that's another statistic which is commonly seen, correlation coefficient, regression analysis, and I'll talk briefly about how to interpret meta-analysis in the next presentation. So to begin with, as I said, we deal with the data in statistics. And this data is in the form of variables. Variables could be anything. It could be age, it could be gender, it could be incidence of MI, it could be incidence of diabetes. So it could be blood sugar levels. So it's all variables. And then we have certain values. So every variable will have a value, and we keep collecting those values, and then becomes a data set, and then we analyze it. So there are two fundamental types of variables. One is a metric in which we measure the value of a variable. And second, we have categorical variables where we have only yes or no. So we can categorize your patient or any data into a particular category. That's called categorical variables. And I will discuss these in some detail. So metric variable are again of two types. One is continuous variable and one is discrete. Continuous means it's a continuous variable, like for example, blood sugar. It can be measured in decimals also, like blood cholesterol or any such thing which can be measured in a totally continuous manner, including decimal points, is called a continuous variable. And then we have discrete variables, where you have to measure, but it's not continuous, means it just like consists of whole numbers. So for example, you have Chairs-Basket score or parity. So they can be measured only in terms of whole numbers. There's no percentage points there. So these are called discrete variables. And then we have categorical variables, which can again be nominal, which relate to like naming things, not numeric, and they can be arranged randomly, and they could be ordinal. So there can be two types of categories, nominal and ordinal. I'll tell you the difference between the two. So the basic question when we want to look at the variable is we ask the question, has the data got units? If it has units, then we can measure it obviously. And we can either count it or we can measure in a continuous metric. Or they can be put in a meaningful order or not, like categorical nominal and categorical ordinal. Ordinal has an order. Now, let me give you an example. So this is a paper. This is a study that we, like Indian Heart Rhythm Society, did on atrial fibrillation. And we have this table on the left, table 3, where we have various variables like heart failure, fast VR, angina, coronary interventions, valvular interventions. Now, it doesn't matter whether we put them in a particular order or not. So they are nominal categorical variables, where it does not matter whether we put digoxin toxicity up or heart failure down or whichever way we want. On the other hand, on the right side, if you see, we have this, for example, Chad's-Vasque score, 0, 1, 2, 3. They have to be in a particular order. It would look very odd if we put 2 first and then 0 and then 3 and then 1. So whenever it's a very minor difference, just nomenclature. So if there is an order, we call them ordinal. If there is no order, we call them nominal. So it's a very simple thing. And then we have the continuous variables. For example, we have the age here, we have the, now gender obviously cannot be measured in numbers, so it's a categorical. But male female doesn't matter, we can put females up and men down, doesn't matter. So they are what we call nominal categorical variables. Then an important thing is frequency table. When somebody asks you what is the frequency, just drop a frequency table. Frequency table basically means that you put the variable on one side and you put the numbers on the other side. Something very simple. So unless you keep repeating in your mind what's a frequency table, it's something very, very simple. That you put the variable in one line and you put the numbers in the other, it becomes a frequency table. So frequency table means we just counting the number of variables in a particular data set and putting them there, it becomes a frequency table. Now, when you encounter a data set, you have two things in mind. One is that you want to know what is the central tendency. And second is how much is the variation. So for example, you're looking at, say, serum cholesterol level in a particular population. And so you want to know what is the central tendency, what is the mean or average. And that is called, and there are three measures of central tendency. One measure is mean, that is a arithmetic mean, that you total all the values and you come to a particular, and you average them, that becomes an arithmetic mean. Second is a median, which is 50th percentile. I'll briefly illustrate how median is derived. And third is the mode. Third, mode means the value that occurs most often is called mode. And then we have measures of dispersion as to how much the data is varying. So the variation in the data can be either in the form of, it can be seen either in the form of range. For example, if you're told that your study group had an age range from 2 years to 80 years, so that's a very wide variation. And the second possibility could be that your study group had a range as an age range of 50 to 60. So, this is a study on the middle-aged population. So the range is very less. So, the variation is less. The second way is standard deviation. So that we all know that we calculate whenever we describe a mean, we also tell the standard deviation, which means that how much the data can deviate from the mean. So that is another measure of dispersion of values. And third is the variance, which is less commonly used, but basically just a square of the standard deviation. In fact, when we calculate the standard deviation, we have to have a square root of the certain value. And if we don't do that square root, that becomes a variance. So first of all, when we calculate the standard deviation, I don't want to go into that actually. So let us not go into that, how to calculate standard deviation, how to calculate variance, because that is where the problem occurs and the interest also wanes. But it is suffices to know that if we want to know the measures of dispersion, we look at the range, we look at the standard deviation, and we look at the variance. So I will give some examples as to how these look like. Now, this is what we call the median. A mean, I told you that a mean is just basically arithmetic total of all the values, and you divide it by the total number, that becomes arithmetic mean. But median is slightly more complex. So median is when you put all the values in sequence from the lowest value to the highest value. You can see at the bottom. Now this is, for example, this may be the cholesterol level, and or this is actually height. Okay, so it's a height in centimeters, and there are certain number of subjects, both males and females, and we have arranged the height from the lowest number to the highest number. So lowest number is 153 for the males and highest number is 178 here, and they are all arranged in a sequence, that is from the lower to the highest, in a manner that the percentile value can be calculated or looked at. The central value is called the median. If it's an odd number, it will be one value, like in this example it's 164. If it is an even number, you will have two values in the center and you have to take an average of that. So that becomes the median. Now the important thing is how median is displayed. Let's go back to the previous one, uh, this one here. So in this, you can see in the right table, they have mentioned age, mean plus minus standard deviation. So we have 54.7 plus minus 15.9. And they also mentioned the age range, 15 years to 96 years. So all the three measures of, and then we have the median from 55, and then there is another value which is called 4267. This is 25th percentile to 75th percentile. Now this is also called IQR. Whenever you will see in the papers that the authors have mentioned median, they also mention IQR, which is interquartile range. So when we calculate the median, we divide the data set into 4 points: 25th percentile, 50th percentile, 75th percentile, and 100th percentile, which is the top value. And the lowest value, of course, is 0. So the median is the 50th percentile. But because there may be a lot of variation in the first half and the second half, we also typically mention the 25th percentile and the 75th percentile. And that is called interquartile range. You see this plot? This plot is called box and whisker plot, where you have in the center, you have a box, and the box has a horizontal line, which is actually the median. And then the box has the upper range and the lower range, which are actually 25th and the 75th percentile. So the box represents the interquartile range, which is from 25th percentile to the 75th percentile. And then we have the outlier values, and this is the top 100 percentile and the most lowest value. Now sometimes, like in this case on the right side, we have a outlier value, which is 142, which is very, very different from rest of the group. So sometimes the authors will put a separate dot here, which basically would represent that value. So in this case, it is 142, and that's a outlier value, which has been, otherwise the graph would have got distorted too much. So this is another technique that sometimes is displayed, that you see an outlier value mentioned separately. So that's how you should look at these graphs. They represent the median and they represent the interquartile range and the top value and the bottom value. It's a very descriptive graph, but unless we know how to read these graphs, we will obviously not know. So, and then this is another example. You have the median, you have the interquartile range, you have the lowest value, you have the highest value, which you can see from the this y-axis. Then we come to the frequency distribution shape. Now, most of the human values, whether we look at blood pressure or pulse rate or blood sugar, blood cholesterol, they are all distributed in a manner which is called normal distribution. So you will have most of the people, supposing you take 1 lakh people and measure their any parameter, a large number of them will have the mean value. And as you go sideways, less number of people will have the lesser or the higher values. So for example, if you look at the blood pressure, if you check the society, a lot of people will have a systolic blood pressure of 120, and then some will have 130, 140, lesser number will have 160, even lesser number will have 180. Similarly, on the lower side, they will be distributed in the same manner. So most of the people will have this coming in the center, and that is called a normal distribution. And what is a skewed distribution is like something like this, that there are more people on one side and less people on the other side. So when you look at the normal distribution, it's called Gaussian normal distribution graph, where 68.28% will be having will be represented by mean plus minus one standard deviation. Okay, so if we take the value mean plus minus one standard deviation, that will cover 68.27% of the population. If you take mean plus minus 2 standard deviation, that will cover 95% or 95.45 to be exact population. And if we take 3 standard deviation, that will cover 99.73% of the population. So most of the, and this is a very important part of understanding as to what is the normal distribution curve, what does standard deviation cover, 1 standard deviation, 2 standard deviation, 3 standard deviation, and how do we, what are the abnormal or skewed distribution graphs. And if you look at here, now this is the top one on the right panel is a skewed deviation, but this is how the mode helps, that the mode tells us what is the most commonly found figure in a particular data set. So that becomes the mode. The median, as I said, is the median of the 50th percentile, where the data is equally distributed 50-50%, and mean is the sum total. The advantage of the median is that when we look at the mean, for example, the mean may get very much so no, sorry, where is the that yeah. So the median takes care of outliers. Supposing you have 10 values and one of them is abnormally high, very high, that can change the mean completely. But when it comes to median, it will not change the median. So whenever you have a very data which is very widely distributed, median helps you there. Now we come to the a very important thing, which is called the concept of confidence intervals. See, when we do a study, we do it on a very small population. We can, in any trial, we can include 100 patients, 200 patients, 300 patients. And supposing you are doing a trial on hypertension or CAD patients, or patients who are undergoing AF ablation, or patients who are undergoing, say, angioplasty, you can include 100, 200, 1000 patients. But globally, there will be lakhs and lakhs and millions of patients of the same size, of the same disease. So that total population, global population, is called the population of that particular entity that we are trying to study. Of that, we take a very small sample that is called study population. Now, obviously, there will be uncertainty here. Whenever you have a huge population, which may consist of millions of patients, and you are studying a small number, there will be uncertainty, because if you take another sample, you may get somewhat different result. If you take a third sample, fourth sample, it may come up with some different results. So there is always uncertainty. And that is the main requirement. All the statistical models, what they do is they measure that uncertainty for you and help us take decisions. So if you say what statistics does, what it does is it measures, or it uses the probability models to measure that uncertainty. It quantifies the uncertainty for us and tells us what is the probability of certain thing happening. Now, I'll give you an example of what confidence interval actually means. So supposing you are a buyer of say oranges, and you want to ascertain the quality of oranges, you want to know the mean weight of oranges. So you take 50 fruits out of this big heap, and you measure and you come with a mean of 230 grams plus minus 20 grams. So 230 is your mean and 220 is your standard deviation. So that's how you will represent that. I've taken a sample of 50 fruits, and that gave me a mean of 230 plus minus 20 grams. And then you calculate the confidence intervals. And that gives you a value of say 198 grams to 268 grams. So this is how it is represented by a horizontal line with arrows on either side and a center point. Now the center point is called point estimate, and this left side is called lower bound, right side is upper bound of the confidence interval. And what that means is that uh, if you repeat this experiment endlessly, 95% of the time, this interval will contain the true value. That is what it means. So it is giving you a measure of doubt, because I may ask, yeah, you have taken only 50 fruits and this is a very big heap. How can you be sure that 50 fruits will actually give you the correct mean of the entire lot? It cannot. It can give us certain estimate, and if we want a more true estimate or the measure of doubt, then it will give us a confidence interval. Okay, so if you repeat this experiment endlessly, 95% of the time, this interval will contain the true value. So that will give us an idea as to, yeah, okay, I may be buying these oranges, may have a weight from 198 to 268 mean value. If you want a better estimate, it seems very logical that you increase the number of sample size. So you take 500 fruits and you come up with certain value that gives you a narrower confidence interval, because now you are more certain. You have taken a bigger sample, your confidence interval will shrink automatically. Now it will give you a more correct value. If you take 2000 fruits, the confidence interval will be further smaller. So you have it is basically quantifying uncertainty for you, making it more certain definitely that this is the interval that will contain the true value if you repeat the experiment 95%. And most, it's by convention that we use the 95% uh, confidence interval. There are some trials which are also done in 97.5 confidence interval, but mostly what we use is 95% confidence interval. Now I don't want you to go and ask me the question, how do you calculate this, because that is something which I said at the very onset. That is where we start disliking statistics. We will ask the statistician to do it for us. It is for us to know what is confidence interval, what does it actually mean, and how do we interpret a confidence interval. If you want a perfect estimate, you have to measure and count all the fruits and then find a mean that will give you the actual true value. But that is not possible. You cannot study all patients of hypertension or hypercholesterolemia or CAD or any particular condition, because that is not possible. So we always take a small sample, but we take a sample which is adequate, which will not give us a very useless kind of confidence interval, because we need to make some clinical decisions. We need to decide about a particular treatment. So we have to have a reasonably sized data set or sample size. If you take a very big sample size, you have a problem of enrollment. You cannot enroll a lot of patients within a certain time. If you take too many years, then the whole utility will be lost, because by that time the treatments also change. The new treatments start coming, or the same technique will have evolved to a different level. So you have to finish the study in a certain time. And also some studies may turn out to be very expensive, because they have some implants or some drugs which are very expensive. So based on the cost of the study, based on the number of patients in that population, you have to come to a fair degree of sample size, which again can be calculated by the statistician. So you have to ask the statistician that to measure so much of difference, what should be our sample size? And you have to find a sweet spot, because you cannot have a very big sample size, otherwise your study will not take off. because of cost and time constraints. So these are the important things here. Now we come to another important statistical, what you may call semantics, which is odds ratio, hazard ratio, and relative risk. And these are often very confusing, and we must know what exactly they represent. Now, odds ratio basically is when you have some particular event happening versus not happening. So, for example, you have, say, for any condition, if a percentage is say 3%, for example, it could be stroke percentage, it could be stroke stent thrombosis percentage, it could be MI percentage, is say for example 3%. That means the odds are 3 versus 97, because in other 97 it will not happen. So the odds ratio becomes say 0.031. That is the odd of something happening. And in the control group, for example, if you have 2%, so it is 2 versus 98. So when you measure odds ratio, it's basically something happening versus something not happening. So there are two situations, something happening versus not happening. So that is the ratio of, that's called odds ratio. And when you take a ratio of these, it becomes like, for example, in this case, it becomes 0.231 divided by 0.02, it becomes 1.55. The relative risk on the other hand, on the other hand, has actual percentage of something happening. So for example, the same thing, if you see 3% means 3 out of 100, so the risk becomes 0.03. And in the control group it is 2%, so it becomes say 0.02. So that is called relative, that is called risk. And when you measure, calculate the relative risk, it becomes 0.03 divided by 0.02, it becomes 1.5. So they are often used interchangeably, odds ratio versus relative risk. And if the incidence is small, it doesn't actually matter. As you see in this example, because we are comparing 3% incidence versus 2%, and the risk and the odds ratio is 1.55 and the relative risk is 1.5. So it doesn't matter much which one do you use. If you increase the percentages, for example, here you have something happening 30%, so the odds become 30 against 70, so it's 0.43. And in the control group it is 20 against 80, so it's 0.25. If you take the risk, then it is like 30% means 0.3, control 20% means 0.2. And if you take the odds ratio, it will become 1.72. If they take relative risk, it will become 1.5. Now here the percentages are still quite high, 30% versus 20%, but there is not much difference still in the odds versus relative risk. But if they really start increasing more, say for example, somewhere I read this example of say Titanic, where in Titanic crash, 80% men had died and females only 25% died, because they were given preference in the lifeboats and all that. So less females died, but the odds for the males were 4, because they were 80/20 against 20. So odds were 4. For the females, it was 0.33. So odds ratio was 12. And if you take the relative risk, it is much, much different. So as the percentage of any incidence or any particular outcome increases, you have to use relative risk. Otherwise, it doesn't matter. So then we come to hazard ratio. Now, hazard ratio again is something which is often confused with relative risk, and it may actually be equivalent to relative risk. But here they also take into account the timeline of a particular event happening. And hazard ratios are typically utilized when we analyze the two survival curves, the Kaplan-Meier curves. And that is when we calculate the hazard ratio. It is something similar to relative risk, but they are not exactly similar. I will again not go into the details of how they are calculated, but it is suffice to know that they are calculated. They also take into account something happening, how fast some particular event happens. For example, I'll give you an example. So you're say studying the stroke incidence in patients with atrial fibrillation in the control group versus warfarin versus NOAC. And you find that in one group there was 3% incidence, and one group it was 5% incidence. So you know that there is a significant difference. But if I tell you that the 3% happened within 1 month of the study and the 5% were spread over 2 years, then you know that this is different because uh, the timelines are completely different. So hazard ratio, as I said, also take into account the timeline as to how quickly the events happen. And it is again calculated according to a formula, and we will not go into the details. But these three statistics or terminologies, hazard ratio, relative risk, and odds ratio, should be understood and utilized in a particular manner. Now we come to a randomized clinical trial as to how it is conducted and what exactly it means. So when we look at the clinical research universe, we have a very hierarchical system of evidence. At the top of the heap are randomized clinical trials, and when we combine them, we come to meta-analysis. Some people believe that randomized clinical trials are the best. Some people believe meta-analysis are the best. They have both have their own issues, because meta-analysis is when we combine several trials, and they may they will it will depend on what trials the person includes for meta-analysis, because you can really skew the results of meta-analysis the way you want by including or omitting certain trials. Then we have case control studies, then we have cohort studies, which are basically a small group, and then we have cross-sectional studies, case series, and case reports. So this is a reducing credibility of evidence. At the top of the heap, as I said, are randomized clinical trials. So, as I said earlier, a trial, typically we plan a trial to test effect of a drug or intervention or exposure on a group of people. So there is a huge global population of a particular entity, and we take a small study population. Obviously, so for example, there may be 5 million patients and we take a small number. This is called a sample, and we try to apply the results to the entire population. Now, whenever you try to apply results of a sample to entire population, there will be uncertainty. And as I said earlier, statistical models, they measure that uncertainty for us and help us take decision. So as I was talking earlier, if you take two samples from the same population, you do a study in Delhi on CAD patient, you do a study in US on CAD patients or somewhere else, one in GB Pant, one in Escorts, one in AIMS, and we all may come to different conclusions because the results may vary a little bit. Uh, and that is quite natural. So it may happen, this is where I was talking about the meta-analysis. So it may happen that if you do 50 studies globally, 5 of the 50 studies are positive and 45 are negative. Now, when someone wants to do meta-analysis, he will look at the published studies first. So these 5 studies which are positive, they get published. And out of 45 which were, say, negative, only 2 get published. But the person takes all the published studies, 5 positive and 2 negative, and comes to a conclusion that the study results are positive, or this particular treatment is effective, while ignoring the 43 other trials which were negative. Now it is possible for the researchers to go to registries, because in US and many countries there are trial registries. In our country also, DCGI I think has a trial registry where you have to, in many situations where particularly where you want to have reimbursement or you are taking approvals from the government bodies, you have to submit the trial, and subsequently you have to submit the trial results also, whether they are positive or negative doesn't matter. And those registries are available on the websites. So a researcher who wants to do a serious meta-analysis can dig out that data also, the unpublished data, and combine all the studies into the meta-analysis and come to more meaningful conclusions. So anyway, let us see what we do. So we take a sample and then we divide it into 1 or 2 or 3 groups depending on what we want to study. So for example, if we are studying, say, anticoagulation and atrial fibrillation, we may typically we don't use a placebo group, because we know now that the anticoagulation is very effective. So we will take only 2 groups. One is, say, against established, say for example, warfarin, and one against some NOAC or 2 NOACs. But in some new treatment, we also take a placebo sometimes. So there may be three arms, like in companion arm on ICD, where there were three arms. So the many trials will have three arms. So, and then we randomize our patients into one and the other. So we do this selection randomly. We will take one patient in this group and next patient to this group, one patient to this group, next patient to this group. And there are randomization itself is a whole science. There are many methods of randomization. It's done randomly by computerized random generation, number generation. And if properly done, it makes the groups completely similar in every aspect except the exposure that we are trying to study. So the exposure is what you're trying to study. For example, you are giving a particular drug, it is called exposure. If you're seeing the effect of exercise, you will give exercise in one group and not in the other. It's called an exposure. So exposure could be anything. It could be a procedure, it could be an intervention, it could be a exercise, it could be yoga, it could be a particular pharmaceutical agent. So that is called a exposure. And the benefit of randomization is that your groups become absolutely similar in every aspect. Say, for example, age range, presence of diabetes, hypertension, smoker, non-smoker, everything will become same because you've randomized them, and they will differ only in terms of exposure. So there are certain things that we want in a randomized trial. One is that the group should represent the population being studied, which means that sample size should be good. If you take a very small sample, it will not represent the population. So the sample size should be good. Second is that randomization should be done scientifically and should be maintained throughout the trial. Sometimes there is a lot of crossover in the treatment. So then it basically, you can say that the randomization was not maintained. The group should receive the treatment as prescribed. Again, the crossover, too much crossover reduces the value of your clinical trial. And there should be minimum dropouts on follow-up. So sometimes it happens that you start with 1000 patients, 500 in each group, and by the time you end the study, a lot of people have dropped out. They have withdrawn consent, they have migrated, they're not coming for follow-up. So if there is severe or very large amount of dropout, that also reduces the value of the trials. So I will discuss it with one example, which is a very good trial or recent trial. It's called CABANA trial. This was a trial done on atrial fibrillation patients to see the effect of atrial fibrillation versus drug therapy. And eventually the trial was declared negative, but it gives very good statistical discussion points. So in this trial, they took 2,200 patients of atrial fibrillation and randomized them to catheter ablation arm and half of them to drug therapy arm. So about 1,100 patients were randomized to each arm. I'm losing the track of time. Let me see what is the. Oh, Dr. Mohit, you can interrupt me whenever.
No, no, please continue, sir. It's going very well.
Is
Please
it okay?
Yeah,
All right.
please.
So these patients were randomized to two arms. But the problem was that in the catheter ablation arm, 102 patients did not receive catheter ablation. So about 9% patients did not receive the prescribed treatment. And in the drug therapy arm, 300 patients received catheter ablation. So about 30% patients crossed over to this side, and here 100 patients crossed over to this side. So there was a big confusion here. So what they did was, when they did three types of analysis. One is called intention to treat analysis. That is how for last several decades we have been analyzing the trials. That is intention to treat analysis. That is, patients will be analyzed in the same arm, whether they receive same treatment or they receive the other treatment. So for example, if you do the ITT analysis, that is intention to treat analysis, even the patients who have received catheter ablation, they will be treated they will be studied in the or included in the drug therapy arm for the purpose of statistics. And patients who did not receive catheter ablation, they also will be received or analyzed in the catheter ablation arm. So that is the drawback of the ITT, but that is how conventionally we have been using the analysis. Now the second way, they tried to analyze it by treatment received. So what they did was, that patients who did not receive catheter ablation, they were included with the drug therapy arm, and patients who received catheter ablation in this particular arm, they were transferred to the catheter ablation arm. Now, this is where the problem comes. If you analyze a trial in this manner, that is treatment received arm, then you're not maintaining randomization, because now your originally randomized group has become mixed. So you cannot, and this is a wrong way of analyzing data, but a practical way, because you should also look at what exactly happens when you analyze the data according to the treatment received. This also gives some important information, but technically the purists will say that this is not the way you should analyze, because this you're losing randomization. The third way this trial was analyzed was per protocol analysis. Now, this is another term that you must know. What is per protocol analysis? Because some trials use this method also. Here, what they did was they removed these patients from the catheter ablation arm who did not undergo catheter ablation, they were removed. And similarly, in the drug therapy arm, patients who underwent catheter ablation, they were removed or deleted from this. So all the patients uh, who remained, out of 1100, 300 were removed. So they remained in this arm, and here 100 patients were removed. Now this is called censoring, that you, a type of censoring. Censoring is another term that you must remember. Whenever you have two arms or three arms of data, and gradually your patients are either removed, like in this example. Sometimes it may happen that you may have to exit some patients from the study because somebody was supposed to be blinded, got unblinded, so you remove him from the study yourself. Some patient says, "Ki doctor, I cannot continue to be in the study. I'm leaving the town." So you exit him. Some patients die of some, say, accident, for example, unrelated thing. So they get exited. So that is all, that data is considered to be censored, CENSOR, censored. So this is called censoring. Whether you, for whatever reason, whether you exit some patients or the patients exit themselves, they are not analyzed, and that's called censoring. So too much of censoring happened. So this way also was not exactly correct, because you should not have so much of censoring that 30% patients and 10% patients, they get censored. So that again reduces the quality of your study. Lastly, I want to discuss the hypothesis testing. Now, that's a very, very important, because this is central to the whole statistical discussion as to how do we test a particular hypothesis and derive a p-value. So when you do a trial, let us continue with our randomized trial. So supposing you have taken a sample and you divide that sample into two arms. One is the treatment arm, one is the control arm, which may be placebo or which may be another drug or another intervention. So you have two arms of patients, control group and the test group. And you always begin, every trial is begun with the assumption that both groups are same. So that's called null hypothesis, or H0. You begin with the hypothesis that there is no difference between the groups. So that's the default. And then you have in the back of your mind, you have an alternative hypothesis, that is there is a difference between the groups. So, and that is what you expect also, that is what you want, that your new treatment or new drug should be effective, more effective than the control uh, therapy that you are testing, because that is the whole aim of the trial. So that is called H1 hypothesis, H1 or HA, alternative hypothesis. And by doing the trial, you expect or you hope that there will be difference between the two groups, and you will be able to reject the null hypothesis. Your aim is to reject the null hypothesis. But while the trial is going on, you have to hold that hypothesis that both groups are same and there is no difference. Another thing that you must know is that there is no way to 100% prove whether null hypothesis is true or false. You cannot know, because you're not studying the whole population. You have to, for knowing whether the null hypothesis is true or false, or whether the two groups are exactly similar or not similar, you have to study the entire population, which is not possible at all. So you have to, because you're taken a small sample of a group of patients, 100 patients, 200, 500, and by studying them you can come to some probability. You cannot know for sure. So you have to accept or reject null hypothesis based on that probability, and that is what statistics is all about. So the interpretation of p-value basically involves certain facts about p-value. One is that if you, typically we say that, okay, if it is less than 0.05, we know that the new intervention or drug is effective. It doesn't prove it. This p-value of less than 0.05 does not prove that the new intervention or drug is effective. It gives you a certain probability. It cannot prove 100%. Similarly, if the p-value is more than 0.05, it does not prove that the intervention or drug is not effective. Neither does this tell anything about the trial results being true or false. It basically tells us about a probability of obtaining a data as extreme or as diverse or as different as observed, given that the null hypothesis is true. So this is something that I want to explain in more detail by giving an analogy. And this is the best analogy. This is given by, I heard it from Dr. Paul Wakim of the National Institutes of Health, USA. He gives this coin toss analogy. So basically it goes like this. So if I come to you and I say that I have a coin which has head on both sides, it's an abnormal coin. And there are so many coins in the, so you may or may not believe me, because you can say that, and I say that I have a coin which has head on both sides. You may say, show me the coin. Only then I can believe it. It's not possible. How can a coin have head on both sides? And I say, I cannot show you the coin, but I can toss it and see how it falls on the floor. Anyway, uh, this may be an important thing for you. You may be a finance minister. You may have to order expensive investigation, but it is important for you to know, because, like for example, if some manufacturer comes to us that this new drug is more effective, we say you have to prove it. How can we believe that this new treatment or new drug is more effective? So it is important for us physicians to know that a particular new therapy, like for example, we are suffering COVID pandemic. If someone comes with a particular treatment for COVID, it is, we cannot just believe it that it is effective, but at the same time we cannot dismiss it also. So we need to do some experiment with the new treatment to know whether, what is the probability of it being effective. So here, supposing we say that, okay, I'm tossing the coin, and supposing with the first toss it falls on the floor with the head up. Now you still will not believe it, because you know that the possibility with a normal coin is 50% that it will fall with the head up. So you say, I cannot believe still that I still believe it's a normal coin, and you're just bluffing me. I say, okay, I toss it again. I do it 2 times. Now 2 out of 2 it has fallen with the head up. Now what is the probability of it still being normal? 25%. Because it is quite possible that a normal coin may fall twice with the head up. But in your mind, you know that the probability of it being normal has gone down now to 25%. So I do one more toss, and now it is 3 out of 3 head up falls. Now the probability of it being a normal coin is only 12.5%. And I'm not ready to show the coin, because that cannot be done. You have to decide whether it's a normal coin or a abnormal coin just based on the head count. Now the probability is only 12.5%. So we do one more toss, and again it's head up. Now the probability has fallen down further of it being a normal coin. So now it's got you thinking that it may actually be a coin with the head on 2 sides. So, but still the probability is 6.25%. And you have read in your statistics that you have to have a probability of less than 5% or less than 0.05 for you to reject your null hypothesis. In this case, the null hypothesis is that no, it's a normal coin. That's your null hypothesis, but you don't want to reject it yet. So we do one more toss and it's 5 out of 5. Now the probability of it being a normal coin is how much? 3.125% or less than 0.05. It's 0.0313 now. So at this point, you may say, okay, because the probability of it being a normal coin is very less, so I am rejecting my hypothesis that it's a normal coin. That was a null hypothesis, so you reject it in favor of alternative hypothesis. You have not seen the coin. I have not proven that it's a abnormal coin, but because it fell 5 out of 5 with head up, you know the probability of it being a normal coin is very, very less. So you can reject your null hypothesis in favor of a alternative hypothesis. So as I said, the P less than 0.05 does not prove that the new treatment is effective. It gives you a probability that yes, there is very good probability that it is effective. Similarly, more than 0.05 does not prove that the new treatment is not effective. Now you see from this coin toss analogy, you see how you with just 0.05 and 0.04 and 0.06, how diametrically opposite decisions you might take about a new treatment. And this is the reason I will come to this discussion also, that the statisticians world over are wanting us clinicians to reject that threshold. This threshold we have set for ourselves, and this threshold has worked for over a century. And we always say, okay, less than 0.05 effective, more than 0.05 not effective. But that is not how the way it is supposed to be. It's a continuous probability, and we have set a threshold. So we want to take a binary decision of yes or no based on something that is a continuous parameter. So at 0.06 we take a certain decision, and 0.04 we take a certain decision. At just 6% probability and 4% probability, we diametrically change our views. Now that is something which is very much a part of discussion among statisticians as to how this problem should be tackled. And now they don't want us to base our decisions based purely on the probability. So the p value basically is a probability of the data being different given that the null hypothesis is true. So the point I was trying to make is that it could still be a normal coin, and the conclusion might be wrong, because it is possible theoretically, even with a normal coin, that it may fall 5 out of 5 times with the head up, and the probability may be 3%, but there is a probability. And this error is called type 1 or alpha error. So this again, this terminology will come in the trials as to what is the type 1 error or alpha error, and what is beta error or type 2 error. So type 1 error is when you make a wrong decision about the trial being true. So if you basically reject your hypothesis, even if it is wrong, it's called if you um, reject it when it is wrong, then it's called type 2 error or beta error. And so it may happen both ways. That it may happen, for example, that you reject the null hypothesis when it was actually true. It's called alpha error, and typically it is less than 5%, because we set this threshold of 0.05. So up to 5% chances that you may go wrong by rejecting your null hypothesis. Similarly, if you go on the other side, for example, if the p value was more than 0.05, say 0.06, and you fail to reject the null hypothesis, you declare the trial negative, while actually it was effective. So it is quite possible that your p value in a trial with the new treatment came 0.06, and you declared that the trial is negative or the new treatment is not effective, where in fact it was effective. That is called beta error. And typically it should be less than 20% or 0.2. So when we do a study, we always have to calculate these things a priori, because whenever you design a trial, you have to know what could be the beta error with this particular sample size. So you create a sample size based on the statistical power. and the power has to be 80% or more. Power me basically is decided by the beta error. So because we want the beta error to be less than 20%, that by corollary, it means that we want the statistical power to be 80% or more. And that for to know to have 80% power, you have to have certain sample size and certain follow-up duration. That will tell you what exactly is the power. And again, we don't want to know how to calculate that. We will talk to our statistician that we want to have this much. Some trialists, they want 90% power, but you have to have at least 80% power for your trial to be have some credibility. So these are the terms that we must know. What is the alpha error? What is beta error? What is the statistical power? Which is basically 1 minus beta. So it should be high statistical power, zero point 0.8, which means 80% or more. And this will guide us about the sample size and the follow-up duration based on the historical data, which means you have certain expected percentages, and depending on that, you calculate it. So typically you have the trial results shown in this manner. You have the graph like this, where, for example, you have drug A on this side and drug B on this side. It could be a placebo also. And you have a central line, which is called the line of no effect. Or here the ratios are coming to one, whether it's a relative risk or hazard ratio is coming as one, which means there is no difference between the drug A and drug B. So it's being shown here as a central line or line of no difference. If your risk is on this side, then favors drug B. If it is on this side, then favors drug A. And you want to do a particular study for, say, for a stroke reduction, drug A versus drug B. So your clinical hypothesis will be that drug A is expected to be better than B, but your null hypothesis is that there's no difference. So this is what we start with, that there is no difference between the two drugs. And you take, say, 4,000 patients. It's a big sample. You have 2,000 patients in each group, 2,000 patients with drug A and 2,000 patients with drug B. Now with drug A, you find 4% incidence of stroke. With drug B, you find 5% incidence. So there is obviously a reduction, which is 1%, or relative risk reduction is 20%. And you calculate hazard ratio, which may come, say, for example, 0.8, with a 95% confidence interval, 0.68 to 0.96. So this is the confidence interval, and this is the point estimate. You have a lower bound, you have an upper bound. Now you know that your confidence interval is not touching the line of no difference. If it touches, then the trial becomes non-significant. But if the entire confidence interval is on this side, then your drug A, you can say that is more effective, because your confidence interval is coming on this side, the hazard ratio is 0.8, and the entire interval is on this side of the line of no difference. So you call this trial positive. Now, what happens if you take a smaller sample size? For example, in the same study, if you're taken, instead of 4,000 patients, you had taken 2,000 patients with 1,000 in each group, your interval would be wider, because this is something that I showed in the very first slide on confidence interval, that if you take a smaller sample, your uncertainty will grow. So you're not sure of the true value. When you calculate your confidence interval, it will give a bigger range. And once this confidence interval, the upper bound, is touching the line of no difference or crossing it, then your p value will become more than 0.05. Your trial will not show statistically significant difference. So this is the importance, that everything else is same. Your point estimate is same. Everything is same. Incidences are same. But because the sample size was 4,000, confidence interval was narrow, and your study was, it became conclusive. Otherwise, it is not conclusive. So you have to eventually say that both drugs are same, even though the drug A was more effective. So this is what I mean, that you have to have a proper sample size, statistical power to declare a trial positive or negative. And similarly, in this manner, it can be on the other side also. Now, when you look at the, this is called forest plot. Now, here you see in so many studies, you will see this is the way they are shown, that you have the line of no difference, and you have the uh, various subclasses, and you have all patients. So you have the confidence intervals, you have the point estimate, and you can see which is significant, which is not significant. So in all patients, for example, it is significant. Then whether you take LV and systolic volume, it is significant in both. But say, for example, when you take QRS duration less than 150, ICD better or no difference. And when you take more than 150 milliseconds, your TD is better. So it can show difference in your subgroups. So, but this is how we should interpret the confidence intervals. Now, the last thing I want to discuss is what is a non-inferiority trial. This is a recent phenomena that many manufacturers, say for example, you have a new NOAC. They don't want to show superiority with the existing NOAC. They want to show non-inferiority. So, or against warfarin, or you have a new statin. The manufacturers are very happy with showing a non-inferiority so that the drug may get approved. They don't want to show superiority, because if they do a superiority trial here and it becomes like this, then they will have to admit that it is not superior and the trial will be considered negative. So what they want to do is they want to do a non-inferiority study, which means that the drug, so if we are doing a non-inferiority study, we say that the drug A is not inferior to the drug B. That's what we want to prove. And the null hypothesis here will become that the drug A is inferior, because when your clinical hypothesis is that it is non-inferior, your null hypothesis becomes it is inferior. So for doing that, you draw a non-inferiority margin. We are testing drug A. Remember, if the confidence interval falls on this side or the hazard ratio falls on this side, then the drug will not be, it will be inferior. So what they do is they draw a margin here. This is called non-inferiority margin. So in addition to the line of no effect, we have another line which is called the non-inferiority line, or the delta of non-inferiority. So if you find that the drug A is very, very bad, which means that the hazard ratio here is 1.5, which is falling even beyond the non-inferiority line, then it will be considered inferior. But the moment it comes on this side, like this, for example, now this would have been, typically this would have been considered inferior to drug B, because the hazard ratio is 1.2 and it is entirely on this side. So it will be considered bad. But here, because it is within the non-inferiority line, so it is considered non-inferior. This is the advantage for the people who want to do non-inferiority trial, that they just want to show that the drug is not very bad. It is slightly bad is okay, but not very bad. So they set up a non-inferiority margin or delta. And if your upper bound does not cross this line, then the trial is declared that it is, the drug is not inferior, no, is non-inferior. And if it falls on this side, then of course it is superior. So I will give you an example of Rely trial. Now, what was the Rely trial? Rely trial, they studied dabigatran against warfarin, and two doses of dabigatran, one 10 milligram and 150 milligram twice a day, were tested against warfarin. And they designed it as a non-inferiority trial, but eventually they analyzed it for superiority, but they designed it for non-inferiority. And they had this in the statistical section. They had to satisfy the non-inferiority criteria. The upper bound of the one-sided 97.5% confidence interval for the relative risk of outcome need not fall below 1.46. So they calculated a non-inferiority margin at 1.46, which means this was the margin they gave to the dabigatran as against warfarin. Typically, this is the line of no effect in the center, but they gave this much margin for the drug to be kind of less effective than warfarin, to be called inferior. But eventually it turned out to be very good. But even if this entire confidence interval was on this side, as long as the upper bound would not cross this line, it would be okay for them. So that's how it was. Another thing that I want to mention is that the p-values there was a time when p-values were represented just like this. not significant, not significant, not significant. And only the values which were significant, they were mentioned here. This is a very old study. Or there was another way of mentioning, not mentioning p-values at all, except that there was some asterisk marks or something, and it was mentioned here that the p less than 0.05 versus control. So this thing has been practically given now. Now we don't want this to be done, because we want to know the exact probability. So the correct way to mention p-values is this, that we want to know the exact value. What was the p-value, 0.3, 0.38, 0.19, or 0.001, or 0.91, because there's a big difference. Even when they're non-significant, we want to know exactly what was the probability of this being effective or not effective. So less than 0.001 we know is very effective, but we want to know whether something just missed significance or is very highly significant. So we want to know the exact p-values. So coming back to the same analogy, why the threshold of 0.05? Because it has been set to us by the seniors, by our seniors. So it has been there, this threshold of 0.05 has been there for over a century. But last year, there was a conference, 2019, there was a conference of American Statistical Association, which is the biggest body of statisticians world over. And they basically had an editorial which was about 30 pages and which was published as a special issue of American Statistician, where it opens with the heading, moving to a world beyond p less than 0.05. And they said that very clearly, that we should know, we don't want people to write statistically significant, because they say we want to drop this completely, and we should not and neither the variants like statistically different or p less than 0.05 and non-significant, they should not survive, because we should just tell the exact probability, and clinicians should be able to take the decision based on the exact probability whether they want to accept those results or not. So there were many articles in that issue: abandon statistical significance, statistical inference enables bad science, statistical thinking enables good science. Or they say that p-value requires a context, not a threshold. We should look at what was the context, why the trial was done. And we don't want a threshold of probability, because as I said, we should know the purpose of the trial, we should know the process of the trial, context of the trial, because a value of 0.048 and a 0.052 may lead to diametrically opposite actions with very little difference in the probability. So we should know what is the context of the trial. For example, today we are dealing with COVID. Now, anything we are wanting, any antiviral drug, even we won't mind if it gives this much p-value, because that the difference between 0.08 and 0.52 is very, very less. So we should look at what was the context, what was the process, how rigorous the trial was done, whether randomization was good or not, the scientific rigor of the trial, what was the sample size, and what about the plausibility and prior knowledge, the wisdom or the scientific explanation. And in fact, there is another arm of statistics which is called Bayesian arm. What we have discussed so far is called frequentist statistics. And there is another arm which basically puts a lot of emphasis on prior probability. And they say that in, like, for example, in today's time, if you do say 50 studies on say yellow shirt versus green shirt effect of like mortality in COVID, you will find that out of 50, one or two may become positive. If you do 100 trials, two may become positive one way or the other. And if you do meta-analysis, you may come to some conclusion that wearing clothes of a certain color give you protection against COVID. So, but we should look at the plausibility of the scientific explanation also. So I think I will stop here. I've taken more time than required, but these are very complex and important discussions. Maybe we can discuss some other day. So next week I will discuss the other things like what are ROC curves, C index, survival analysis, how to interpret meta-analysis, correlation, regression analysis, and also how to compare two groups, the paired and unpaired t-test and the chi-square test. We will, as I said, not discuss the actual calculations, only the concepts, and because this is very important to understand. Thank you very much.
Thank you, Dr. Saxena. It
And
was
I
a
hope it was useful.
terrific.
Thank you very much, sir. It was a wonderful talk.
We have Dr. Satyavir Yadav and Dr. Sumud also.
Sir,
Three
one
questions.
thing I would like to say, sir, is that when we plan non-inferiority trial, generally when we test one drug with another well-established drug, like you mentioned that in Relay trial, so they planned non-inferiority trial because it's a very well-established treatment. So it's likely that they won't get that superiority margin. So whenever we plan a study against a very well established treatment, so it's better to plan non-inferiority. So that's why
Exactly.
they must have planned like that.
Definitely. And the problem with the only problem with that is that there is no exact way of setting up the delta,
Yes.
non-inferiority delta, because some subjectivity is involved in setting up a delta. So supposing, for example, we do a non-inferiority trial of dabigatran versus warfarin, and even though it is somewhat inferior, we accept it. Somebody else then may do a trial of another drug against dabigatran, a non-inferiority trial, and that we may accept a slightly even more inferior agent, which would not have passed non-inferiority margin with the warfarin. So this is the problem with the non. But I think it is something which is very well accepted in today's time, and they have a place. I agree with you completely.
One more thing, sir, is there anything to do with this non-inferiority margin? Whether if we take, like in this, it was 1.4, so does the results vary with this increased margin or
So in
lesser?
right trial, they were very lucky in the sense that although they had set a margin of 1.46, but even if they had not set at all any margin, even
Yes,
then it would have been accepted because the results were much better actually
yes, yes.
compared to the warfarin. So it was non-inferior anyway.
Thank you very much, sir. Your talk was really very knowledgeable, sir.
Thank you so
Okay,
much.
Dr. Saxena, there are two or three questions, three or four
Yes.
questions that have come up.
Let me
First is
see in the chat box.
not only the chatbot but other ones also. That separately, that how do we calculate the sample size? So if you can cover this particular topic, because many of the residents while do their thesis, this question commonly comes, that how do they calculate their sample size? So if you can put some light in the next topic, next session, it will be
Yeah, I will try to do that, but as a basically, yeah, we can do that, but typically I don't want to get into actual calculations of the sample size and statistical power and all that, because then we will not be able to cover too many terminologies and too many concepts. But I will try to do that. As far as the using mean versus median is concerned, we use, if there is a normal distribution of data, then we like to use mean. And if we have a skewed distribution, then median is a better term, because if there are too many outlying values, they can distort the mean, but the median will be more appropriate in that particular data set. And
can you just explain.
there are tests also to do to see whether your distribution, your data is normally distributed or not. And there are two statistics. One is a you know I don't know the exact names, uh, but there are two tests which are done to see whether your data is normally distributed or not. One is called Romanov Smirnov. Yeah, I think I'll have to go back to my presentation. But so if you talk to your statistician, that when you're planning a study, and if you talk to your statistician that have we verified that our data is normally distributed, he will know that you are a literate person as far as statistics is concerned. So they'll be very happy to help you there. So
Second,
if it is normally distributed, then mean is a very good value.
perfect. And not everybody would be going into the deep statistics, but one thing that is commonly put to the residents is that the odds ratio for this particular patient or this particular thing is 1.20 x5 x whatever you say. You beautifully explained the calculation. What do you mean by that? So how would a resident read it?
Yeah. So that, as I
So this
said,
value it is given.
yeah.
And
So
similarly for the relative risk, they're given a ratio. How would you read it? How would can you just answer it for the residents?
yeah. So basically, For example, if you say throw a dice and your chances of getting a particular result is say 25%, then 25% means 1 out of 4. So 1 against 3. So anything which is happening versus not happening. So if something happens say 5% of the time, the relative risk is 5%. But the odds are 5 versus 95. So 5 happening, 95 not happening. So that is the difference. So it is not exact. So 5 out of 100 is called relative risk. So that becomes very easy to calculate. It's 0.05. But when it is 5 out of 95, it will be slightly more. It will be 0.55. It will not be 0.05. So odds means 1 against the something happening versus not happening. So if something happens, say 4 out of 10, then odds are 4 against 6. 4 happening, 6 not happening. And 4 out of 10, if something happens, relative risk is 4 out of 10, that's 40%. So that is the difference.
Actually, the question will be like we have a tendency to read like this. Now, if the absolute risk is 1.5, we say that 50% more chance that the other person is having that disease or something like that. 50% more, but we cannot say about odds ratio like that because odds ratio could be 12.12 in one of the. So then, how do you?
So when you so what happens is you cannot say like that, but when you get the ratio, it becomes automatically the same thing. So if I can share my screen once again, let me show you in my presentation. Just a moment. Here is that. Do I have it open? Yeah, this slide basically shows it very clearly that can you see this slide? Yeah. So as I was talking, odds ratio is like supposing something happens 3% of the time. The odds are 3 divided by 97 because 3 against 97. So it becomes 0.03. And in this other relative risk is 0.03. So when you take the ratio of the two, control group versus test, it becomes almost same. If the incidence is not very high, the whether you use odds ratio or whether you use relative risk, when you put one against the control arm against the test arm, the ratio odds ratio becomes same as the relative risk. But when the percentages become very high, as the percentage of any particular outcome increases beyond 10-20%, then there becomes a big difference between the odds ratio and the relative risk. So most of the trials, because the incidence of any particular outcome is usually not very high, then both are almost equivalent and any of them can be used. But when the incidence is high, then there is a difference between the two.
So,
But
Dr.
what is
Saxena, the question was that, once you are showing that ratio of 1.55,
yeah.
OR 1.55. Now, a student is given this value, OR is 1.55. Interpret this.
Okay, 1.55.
Yes, that is what. So, once you're given an odds ratio of 1.55
Yeah,
against
that
this, what
means
is, yeah.
yeah, that means the odds are 1.5 times more as compared to the other one. Now, this is only a relative thing, and this it does not tell anything about the actual incidence. For example, when we talk of say intracranial hemorrhage in NOAC versus warfarin, we talk of 0.04% versus 0.06%, and there may be a 50% reduction in the incidence of say intracranial hemorrhage. That's how we say that there is 50% less intracranial incidence because we have calculated the odds ratio or the relative risk, whatever, and we calculate the hazard ratio in the same manner. But that doesn't tell anything about it may be the same thing as something comes down from 50% to 25%, that also is 50% reduction, or odds are 0.05 or whatever odds we calculate. And so it tells nothing about the absolute incidence. It tells about the ratio between the test group and the control group. It tells nothing about the absolute incidence. So whenever we talk of odds ratio or relative risk or hazard ratios, they tell about the relative risk in the test arm versus the control arm, nothing about the absolute reduction. So 1.5 odds risk means 1.5 times more or less, whatever.
If a drug has been proved, shown non-inferior, and so what will you see further? Will you use that drug, next time instead of the established drug? So what else will determine your usage of that drug?
So one is of course the efficacy, and one is the safety. So we have to look at the safety aspect also, and based on that one can take a decision as to how safe the drug was.
Another thing is that if you can just put a light again on the per protocol and the intention to treat, one of the person questions that has come. Just one line, yeah.
Yeah, I will do that. Can I again share my slides?
Yeah, you can. Yes.
Sure. Yeah, so this is what I said was the CABANA trial, which was a trial done on atrial fibrillation patients to see the effect of catheter ablation versus drug therapy, which is a superior treatment. And there were 2,200 patients, and they were randomized to receive catheter ablation versus drug therapy. So there were 1,100 patients, approximately 1,100 patients in both the arms. Now, what happened was that about 100 patients did not receive catheter ablation, which were originally assigned for this treatment. On the other hand, in the patients who were assigned to drug therapy, about 300 or about 29% patients went on to receive catheter ablation. So it becomes very difficult to know for anybody, any bystander to see, because they say that if 30% patients are actually receiving catheter ablation in this arm, then how can you compare this treatment against another? Because there's so much of mixing. But the convention has been that we analyze the two arms just by the intention to treat basis, that when they were assigned to this arm, they remain in this arm. Whether they receive this treatment or don't receive this treatment, receive the other treatment, but they will be analyzed as if they are in the same arm. So even the patients who did not receive catheter ablation, they were analyzed in the same arm
Catheter ablation.
and the catheter ablation arm. And in the drug therapy arm patients, some of them, a lot of them in fact, 30% patients received catheter ablation, but they were analyzed with the patients of the drug therapy. So this is the convention, that we analyze our patients based on intention to treat. And this has been like when we have been having trials of angioplasty versus surgery or medical therapy versus surgery. We have been, even the medical therapy arm, 20% patient may undergo bypass surgery, but they are analyzed as if they are in the same arm, because we want to analyze on
Yeah,
intention
yeah,
to treat basis. But this has its drawbacks. As I said, there's a lot of crossover. If the crossover is too much, then the quality of evidence becomes weak. If there is too much censoring, which means a lot of patients exit the study, then the quality of evidence becomes weak. So randomized trial alone is not enough to prove that your trial is very good.
yeah.
The sample size, the crossover, the dropouts from the study, a lot of things decide whether your trial is actually good or not. So this trial lost some respect because of too much of crossover in the intention to treat analysis. Now they also tried to do the as per treatment, because they said ki catheter ablation will help only if it is performed. If it is not performed, how can it help? So in the drug therapy arm, about 300 received catheter ablation. They were switched to the catheter ablation arm. And the patients who did not receive catheter ablation while originally assigned to this catheter ablation arm, they were included in the drug therapy arm, because they said that this is the drug therapy patients and these 300 patients are actually catheter ablation patients. So let us include them with the catheter ablation arm. Now, this showed benefit that, yeah, catheter ablation in the patients who were performed catheter ablation, they did better as compared to the patients who underwent only drug therapy. But the problem with this type of analysis is that it loses the randomization. So you cannot, the purists will say, how can you compare these two groups when they are not randomized? Okay, you have compared catheter ablation versus medical therapy, but then it becomes a non-randomized trial because the patients were originally randomized to this arm and this arm, and there is a lot of mixing now. So the randomization is lost because it is possible that some patients who received catheter ablation had, say, for example, low ejection fraction, and they benefited, while the patients who were asymptomatic, they did not receive catheter ablation, they said we don't want. So these people, these 300 may be more sicker patients, these 100 may be less sicker patients, and you have mixed the less sicker patients in this arm and more sick in this arm, and then you show benefits. So they are not same groups, they are different groups now because you have done mixing, you have lost randomization. So it becomes a non-randomized trial showing benefit of catheter ablation. So it loses the quality of evidence again. Then what they did was the per protocol analysis, where they said, okay, we will censor these patients. Catheter ablation arm, okay, those who did not receive catheter ablation, exit them from the study. Let's have only 1,000 patients with catheter ablation. Similarly, patients who were assigned to drug therapy, those who chose catheter ablation, let us exit them from the study. So we have only 800 patients here and we have 1,000 patients here. When we compare, they are randomized group and we have exited a lot of patients. But again, too much of data, too much of what you call dropout, too much of censoring also reduces the quality of evidence because it is not considered healthy in any trial if too many patients exit from the study, and that too asymmetrical number. From this group 300 patients, from this group 100 patients, they exited the study because they were censored. So this was also, so there were three types of data analysis: ITT, treatment received, and per protocol.
Okay. Thank you so much, Dr. Sumod. Any questions, Dr. Satvi? Any?
When incidence is high and we got both the absolute risk reduction, we got the relative risk reduction and odds ratio so grossly different, which one we should follow? Which one should be more accurate?
Relative risk.
Sir, how much crossover is acceptable, sir, in term of percentage?
So it would again depend on the sample size and all, but generally should not be more than 10%.
But we generally
Okay.
don't use absolute risk much. We don't say about absolute risk much. And also about the number needed to treat, that is also mentioned, sir. That's, sir, you not mentioned.
Yes. So number needed to treat. No, I did not, because that's a calculation which the statistician should do based on the expected benefit, expected rates, and based on that, and that is what will decide what is your sample size, numbers needed to treat. Is a post trial calculation based on the results that we find. So I've not gone into that.
Okay. If there are no more questions, Dr. Satvi, Dr. Sumod, and all our friends, thank you so much for, sir, a fantastic job. It was definitely a great learning, and I think
Thank you
some
so
of
much.
the very important concepts have been cleared for all of us because we as clinicians are often not going into the details of statistics. My dear friends, actually, let me tell you that the often most of the papers which are not being published are actually nothing more than a statistical jugglery, and you can play around with these statistics and
I know.
play the data, and really how you can understand it. If you know the intricacies, it will be a great interest of for you to actually analyze and interpret and see the results in the true light. So today, Dr. Saxena has very nicely put in some basic principles. And in case you have missed this lecture or you want to listen to it again, It will be uploaded on the PG Track CSI Delhi branch channel, and you can definitely view it. I am definitely going to do that. And we are going to have the part 2 of this session on next Thursday evening, again at 6 p.m. And we will have more clarifications and more in-depth knowledge about the statistical primer. Thank you so much, Dr. Sumodh, Dr. Satvi. Thank you so much, Dr. Saxena, for taking out time for all of us. There are more than 350 residents live at present, and I must inform you, so they are very happy. Definitely, there is no doubt. It shows the enthusiasm that they have. And thank you, Intas, for being the part of this journey. And we'll catch up again next week, Thursday, same time, with the part 2 of the statistical primer for medical professionals. Till
Thank
then,
you, Dr. Mohit. I must confess, I am not a statistician. I am just a clinician and an electrophysiologist with some recently developed interest in statistics. Thank you so
still
much.
really enjoyed every bit of it. Thank you so much.
Thank you so much.